pelvis with grade 4 listhesis. This is also done the same procedure, and we adopted. This is the last follow-up. And this is the unbalanced pelvis with the spine. We adopted the same procedure, and this is the result. So these are the results. We have 22 cases for 4 years, 2019 to 2023. We have only partial neurodeficit, some superficial wound infection with resolves with time. And this is the radiological parameters. These are actually reduced significantly after this. So conclusion, depending on the pelvic tilt, the high-grade listhesis can be divided into balanced and unbalanced pelvis. And unbalanced pelvis usually treated by reduction and fusion. Balanced pelvis usually by in situ fusion. But we choose to use in every cases. So why choose it? We give them better sagittal alignment, solid fusion rate, improved radiological parameters, more rapid mobilization and rehab, and cosmesis. Yes, cosmesis does matter. So do you think Dulux matter? I think it does. I think you know the answer. Thank you. Thank you, sir, very much.
Please come over here to receive your moment, please. Please come over here to receive. We're running short of time.
Next presenter is
কোনটা কই এটা ইলিফ কেন
Please, sir. Sir, Chairperson, sir, I'd like to request you, a person just when finish his talk, he just bring his certificates and crest from your hands, moving through this way, because we have running short of time.
yeah, okay, that is.
Experiment.
Bismillahirrahmanirrahim. Respected teachers, mentors, and learned audience. Assalamu alaikum and very good morning. I am Lieutenant Colonel Shanewaj, Passive Specialist, working in CMH in Dhaka. This is my workstation. Hello. Lumbar canal spinal stenosis. The lumbar canal spinal stenosis is a reduction of the diameter of the central canal of lumbar spine. The normal cross-sectional area of the lumbar canal is 150 to 200 square millimeter. The absolute central canal stenosis will be retailed after when the decrease of the lumbar canal diameter less than 10 millimeter and the cross-sectional area of less than 100 square millimeter. There are some etiologies. There are some congenital and acquired causes may cause lumbar canal stenosis. The prolapse disc causes pain by mechanical compression on the nerve root and chemical neurodiscitis and chemical neuroradiculitis. Epidural steroid application is related to the breaking these inflammation cascade and concurrently reduces the adhesion and fibrosis. There are a wide range of treatment, conservative, epidural steroid injections, and surgical options. This is the first man, James Leonard Corning, who introduced and punctured the lumbar spine first in 1885. My topic, outcome of caudal epidural steroid injection in the management of lumbar spinal canal stenosis, is a study of 50 cases. Rationally, enough data are lacking regarding the effectiveness and safety to these injections. My research question is, does epidural steroid via caudal route work in terms of pain relief and regain of activity of daily living in lumbar spinal canal stenosis patients? Our objective was to ascertain the efficacy of steroid via caudal route. Enough data are lacking regarding the effectiveness and safety of these injections and its superiority to other conservative methods. It was a prospective observational study. It was taken in CMH Kumilla Cantonment and Manamati Cantonment Hospital, Kumilla. From January 2020 to December 2021, 2 years' time, these are the inclusion criteria. These are the exclusion criteria. Measurement tool was Japanese Orthopedic Association score. Sample size was 50, and it was a purposive sampling technique. The procedure for epidural injection, it should not be done anywhere. We should take the informed consent. We should perform general clinical examination, looking for the pulse, BP, etc. We have to have a secure IV line, as there may, after injection, blood pressure may fall. They should be done in OT setup or in a procedure room setup after proper skin preparation and local anesthesia. We have to look. This is the procedure is simple: identifying the sacral hiatus and introducing the epidural cannula or IV cannula through sacral hiatus, directing it to the canal. The composition of injection I used: 20 ml of injection, composition of 2 ml of triamcinolone, 2 ml of bupivacaine, and 16 ml of distilled water to make the volume effect. Results: we assess the patient in pre-injection, 1 month, 3 months, and 6 months after injection. The results are assessed by the rate of improvement by this formula. The cases with good, fair, excellent results are considered to be effective in relieving the pain. These are the MRI findings. This is the sex distribution and comorbidity of the patients. Most of the patients were elderly, and they had diabetes mellitus, hypertension, and heart disease also. Most of my patients are retired army persons, and few are farmer and housewives. The average Japanese Orthopedic Association score at follow-up in total normal score is 29 in normal person, but in pre-injection state, in my study, it was average score was 15.39. At 1 month after injection, it was 23.08, and at 3 months 24.3, and again after 6 months it was declining. It came to 21.03. Most of the patients improved. The rate of improvement, only poor was 14% patients, and another rest of the 60% improved. The patients who were poor, they had severe osteoarthritis and other comorbidities like diabetes and hypertension. That was uncontrolled. My complication was temporary hypotension. 8% of patients developed temporary hypertension, which was corrected by infusion of Hartmann solution, transient hyperparesthesia, and elevation of blood glucose. Elevation of postprandial blood glucose raised to a greater extent in comparison to fasting blood sugar. There is no control group. This is the limitations of this study. In my conclusion, it is a safe and effective method in treating patients who are not suitable for undergo surgery. Thank you, sir. Thank you for patience hearing.
Dr. Shahnawaz, please come over here to receive your memento. Please come over here. Now we move on to the invited talk session. Dr. Junaid, please deposit the mementos in the. Yeah, I would like to request Dr. Fazlul Haq from Bangladesh, and he will be talking.
There was a question and answer session. Before our invited speakers session starts, we can have 1 or 2 questions. Just 1-2 minutes for question and answer session. Do you have any question to anybody? Very short question and very short answer. Anybody has any question? No? It's okay. Then we are a shortage of time. So, Professor Fazlul Haq, please start your presentation. Yes.
Yes. And he will be talking on degenerative L4-5 canal stenosis with grade 1 listhesis. What treatment option would be better?
আচ্ছা ঠিক আছে। হ্যালো, শোনা যায়? আচ্ছা ভাই, প্রেজেন্টেশন তো রাত্রে পাঠাইছি, এখনো কেন রেডি হয়নি? এখানে নাই তো। জোনায়েত,
Problem with your paper. Have you got this your paper there in the computer? Then we can call the second presenter before he gets ready. Uzlok, are you ready?
আমার পেন ড্রাইভ দিচ্ছি আমি। আমি তো রাত্রে পাঠাইছি, কেন আসেনি এটা? এটা পাঠাইছি তো আমি।
Fuzul Haq. Okay. You can present later.
আমি প্রেজেন্টেশন রাত্রে অনলাইনে পাঠাইছি, কি হয়েছে আমি জানি না। Yes. Huh?
Chinmay Nath, he is speaking on modic changes. Is it a game changer in the decision making?
Yes, so it's
Chinmay, please.
ঠিক আছে, পরে করি। নাই তো।
So, may I request Dr. Chinmoy Nath to come over here to present?
এখানে আছে, হ্যাঁ এখানে আছে। Good morning, Chairperson sirs, my ardent audience, my colleagues. Today, I have to talk on a less charted water that is called modic change. We know what is modic change. We know the types, but we discuss it very minimum. I don't know why. But it is related with degenerative change and low back pain. So let us start with the low back pain. The origin of low back pain is still a mystery, but there is a long list of possibilities. The lumbar degenerative spinal elements are the most important cause of low back pain, that is beyond doubt. And one of the possible site of degeneration is intervertebral disc, another one is vertebral end plate and the adjacent bone. And the degeneration of the vertebral end plate and the adjacent spongy bone goes into modic change, which is visible in MRI, and it was first described by Michael Modic from Nashville, Tennessee. But the modic change is not only the end plate change, but mostly in the vertebral marrow and the subchondral area. And until the skeletal maturity, end plates are penetrating microscopic blood vessels that provide vascular supply to the disc, and the end plate also functions as physical barrier. There are different types of end plate change, we all know, and there are different types of modic changes in MRI, like modic type 1, modic type 2, and modic type 3. There are mixed changes as well. But let us discuss the pathophysiology in detail. It starts with the fissuring and tears of the end plate changes, causing depletion of the proteoglycans in the cartilaginous end plate, with reduction of the water content, structural change, and then microfractures and sclerosis on the bony end plate. And the pathophysiology of the disc degeneration also started with the reduction of the nutrient supply of the disc, decline in the proteoglycans, structural changes, and its degeneration. So the changes are in barrier function, herniation of the disc materials up and down, and upregulation of the pro-inflammatory proteins within the disc, as well as the bone marrow surrounding the end plate. These changes are associated with degeneration, but may be initiated by trauma, inflammation, as well as iatrogenic pain, damage like discography. So there are certain strong positive correlation with the modic changes and disc degeneration. This article shows that. And this degeneration is a structural failure due to cell-mediated response, and it has multifactorial contributions like genetics, like micro and macro trauma, like accelerated age-related changes, inflammation, etc. And if we look at the histopathology of the end plate, and this is a normal end plate change, the left-hand side, and there is here the lamellar bone, there is a hematopoietic marrow and the lipid, and modic type 1 and type 2 changes later, which shows in the histopathology. And it is visualized by us in MRI and sometimes in CT, and as well as X-ray in some cases. So MRI modic change is essentially a histological change that is visualized in MRI, and it has substantial inter-observer variability. There are definite etiologies of modic changes like genetics, repetitive end plate changes, instability, deformation of the disc, etc. These are the modic type. This is the modic type 1, hypointense in T1, hyperintense in T2. This is modic type 2, both hyperintense in T1 and T2, and this is modic type 3. So there are certain physiological correlation. Modic type 1 changes correspond with the inflammatory stage, that is ongoing active degenerative process. Modic type 2 is the fatty changes of the bone marrow. It goes from hematopoietic marrow to the fatty marrow, and in type 3 represents the sclerotic changes. There are correlation with the disc height and the modic change. For every 1 millimeter reduction in the average intervertebral disc height of the lumbar spine, there was 1.6 times increased risk of presence of any modic change that is described by this article. And there is fat distribution and modic changes relationship. An android pattern of the fat distribution in the patients increase the chance of modic change. But it is not a one-way traffic. That's like from type 1 goes into type 2, from type 2 goes into type 1. Sometimes type 2 can come back to type 1. The stability of the type 2 changes has been recently questioned. It is neither very stable nor quiescent lesion. Previously, it was thought that it is very stable lesion. The natural history of the modic change shows 14% of the modic changes evolved into another type within 3 years of the pathology. And type 1, 2, 3 changes present different stages of the same pathological process. And sometimes acute ongoing inflammatory process in some type 2 changes converts yellow marrow into red hematopoietic marrow again. And these 3-year-old follow-up have found the evidence of modic type 2 changes may be less stable than previously assumed. And there is very important topic, modic changes and discitis. Many a times modic changes can be discitis. It's a differential diagnosis of the discitis, the major differential diagnosis. And both discitis and modic type 1 changes shows enhancement of the affected bone marrow in MRI. But the signal intensity within the disc often differs between two entities. This is a case in which there is, you can see in the upper picture, there is hyperintense signal in T2, hypointense in T1, so it can be a change of modic, it can be a change type 1 modic, can be a change discitis. But the CRP is high, total count is high. CT scan in case is not done, but tissue diagnosis shows pathological infection, pyogenic infection with Staph aureus. These are two cases in which there are changes, hyperintense in T2, hypointense in T1, but it is very difficult whether it is a modic type 1 change or discitis because there is no other picture. So you have to look into the lab features like CRP, like ESR, total count, and tissue diagnosis. And if we get a diagnosis like this, in this case, in CT scan, if there is a destruction, then it is definitely a infection, not a modic change. And if there is a epidural abscess or surrounding pathology outside the spinal column, then it is definitely a modic change, it is a infective change. So end plate erosion and extraspinal involvement shows a differentiate between modic type 1 and type 2. And this case, low virulence anaerobic infection bacteria, especially the Propionibacterium acnes, can be related with the disc change. And also some degenerative change also related with the disc change. So there is modic correlation between non-specific. Some says that there is related with the non-specific low back pain. Some
go to the last slide.
So, sorry. So only 2-3 slides. So these are the change. Lumbar disc herniation is also related with modic change. Disc herniation is a strong risk factors. This article from India, Coimbatore, India, by Professor Raj Tv shows that there is end plate injury, occult discitis, and autoimmune reactions may be a trigger of inflammatory cascade, which goes into the modic change. And Hayashi suggests that modic change might play a role in the stability of the lumbar spine. And there is a course of modic change in the fusions. After fusion surgery, it goes into from type 1 to type 2. And there is supine positioning. If we can get a supine MRI, from a standing MRI, from a supine MRI, at the same time the size of the modic change increases. So it depends on the stability, it depends on the position of the patient. So the take-home message is, many causative and contributing factors of low back pain like infection, stability, disc herniation, and posture can cause modic change, and etiology and pathogenesis of modic changes are still poorly understood. So further research on modic changes and its correlation with back pain may be a game changer. Thank you very much. And if you are interested in implants of spinal implants, then you can read this book. This is available in Spinjer. Thank you.
Again, to present your paper. Yes. First of all.
আমার প্রেজেন্টেশন কই আমার প্রেজেন্টেশন আরে I'm extremely sorry for this inconvenience. I'm going to present this. It's a debating issue, basically. Degenerative lumbar degenerative spinal stenosis with grade 1 spondylolisthesis. What would be the optimum treatment of this particular scenario? This is a case scenario. As you see, this is very commonly we encountered in our daily practice. So there are a lot of opinions from the different surgeons and lot of chosen the decisions in the different institute, the treatment procedure. So I will going to discuss the evidence-based some information from the literature, how we can have a better decision for this particular scenario. Spondylolisthesis and spinal stenosis is a very common pathology affecting about 14% of the population. Degenerative spondylolisthesis due to the facet arthropathy and the disc degeneration mostly, and it's a common indication for lumbar surgery for the elderly people. Controversies in optimum surgical procedure. Although the lumbar disc degenerative disc disease and the instability is a very frequent indication for lumbar fusion surgery, but there are still large variation for the surgical management chosen by different surgeons and different institutes. Sorry. this first issues coming to the controversy for this degenerative spinal stenosis and listhesis, whether we have to do the decompression only or the decompression with fusion. This is a big issue. The long time I have been observing the last 20 years. But what the literature says, there is a meta-analysis, a systemic review. Currently, there is no enough evidence that adding instrumented fusion to a decompression leads to superior outcome compared to decompression only in the patients of lumbar stenosis and degenerative spondylolisthesis. As you see, I started my career last about 15 years ago. We usually used to do this decompression only and preserving the postal ligament complex. So the patient is still having better result. But as you see, this is the latest review article of 2023. This in conclusion is the lumbar stenosis with or without low-grade degenerative spondylolisthesis can effectively be treated with sole decompression, leaving the majority of the patient is satisfied after initial surgery. This, but why instrumented fusion is necessary? What I find the literature, the decompression without fusion for lumbar stenosis in the presence of degenerative spondylolisthesis has been associated with postoperative instability of the spine. There are a lot of literature and compared randomized study. And there are therefore the concomitant instrumented fusion, maybe the result is better for postoperative and clinical and functional outcome. So finally, the lumbar interbody fusion. Why? The lumbar interbody fusion restored the intervertebral space, stabilized the segment with proper height and lordosis. So finally, the lumbar interbody fusion has been proven an excellent treatment option for lumbar degenerative disc disease. But there are so many procedures like ALIF, PLIF, TLIF, and lateral LLF and oblique lumbar interbody fusion. So many, and but no clear high-level evidence one of these approaches is superior to the other. It comes to the direct or indirect decompression. The PLIF and TLIF both are the direct decompression, and the ALIF, LLIF, and OLIF is all are the indirect decompression. But in conclusion, the indirect and direct decompression and fusion technique are similar, effective in reducing pain and disability in patients of lumbar spinal stenosis and instability. So each technique has its own advantages and disadvantages. So as you see in the PLIF and TLIF, ALIF and all these things, but there are so many confusion whether it is a minimally invasive or the open surgery, which one is the better. But the minimally invasive and advantages is the significant reduction of blood loss, hospitalization time, and the complication and surgical cost. But there is controversy regarding the surgical cost in the minimally invasive TLIF. But there is comparison of OLIF and minimally invasive. The OLIF is little bit a major vascular complication. Endoscopic TLIF or minimally invasive TLIF or open TLIF, all having their own advantages and disadvantages, but similar result in many respects except early recovery in the minimally invasive cases. Endoscopic and the minimally invasive TLIF require repeated intraoperative fluoroscopy, determine the position of the working channel and pedicle screw that causes exposing the patients and the surgeon to a higher radiation doses. So my take-home message is endoscopic TLIF, MIS TLIF or open TLIF, each have their own advantages and disadvantages, show similar result in many respects. So I think we can choose one of these options It depends upon the familiarity of the surgeon and the options available. But the optimum approach should be the chosen based on this individual pathology, anatomy of the patient, and the familiarity of the surgeons and available of the options. But even though the high level evidence is also needed to help in decision making when the fusion is indicated. Thank you for patient care.
So I'd like to request Dr. Fazlul Haq sir to come over here to receive his memento, please, sir. Thank you, sir, for finishing in right time.
Next presenter is yes, Tariq Sohail from Pakistan. He is not present today with us, but he will present virtually. Please, recorded presentation of Tariq Sohail. Yes, start the yeah.
Greetings from Pakistan on behalf of Association of Spine Surgeons of Pakistan to the Bangladesh Spine Society, and I thank to Mr. Chairman and President of the Society for giving me the opportunity to speak here on this August gathering. Any fusion, whether in the spine or otherwise, it has a problem. There's an adjacent segment problem or adjacent level failure, which results in PGK or DGK or adjacent segment disease. And if you look at the function of the intervertebral disc, is a shock absorber, and that shock absorption capability decreases over the period of time. There's abnormal motion there and osteophyte formation, and that changes results into abnormal load distribution in the motion segment, anterior and the posterior, and the passage joint is equally involved subsequently with the increased load transmission in the posterior elements. And these are the various weight distribution studies show that more concentration on the posterior part of the intervertebral disc and the posterior elements. And these are the various anatomical studies show that there's a degeneration there, and that degeneration produces loss of height of the disc. There's osteophyte formation. There is a loss of height of the facet joint, ebonation of the cartilage, and facet capsule becomes hypertrophy. And so is the ligament of flavor. That produces entrapment of various neurological element and produces various pain, paresthesias, and neuroclaudication. Adjacent level disease, if you look at the one vertebra which have been fused by the osteophyte formation, that is kind of becomes sort of comparatively immobile, and the stress concentrate on more and superior level, and the same phenomena of increased mobility and increased osteophyte formation occurs in the most proximal level, and that recruits another level at the top, and that produces sort of extensive degeneration and osteophyte formation in the lumbar spine. So degeneration is not a static phenomena; it's a progressive disorder and produces adjacent segment disease or adult spinal deformity, whatever the situation occurs, whether there's deformation there as well or not. If you fuse one level, there's abnormal changes by mechanical. You convert from mobile to the immobile level, and that produces a problem of if you look at the long bone plating in a stress in the fracture treatment, it produces stress shielding, the stress distribution which is abnormal, and that produces osteoporosis. There is a stress riser at the either end the implant, and there may be fractures through the adjacent bone or the vertebra in case of fusion of the vertebra, and with that result fixation failure or the implant failure, whatever the situation is. And this is very well depicted by the AO studies and also my own studies in my thesis that plating will produce osteoporosis and weakness of the bone. And the bone just at the junction of the plate and the bone is weak, and that produces various kind of pathological situation, and bone becomes fractured. without any significant trauma. And this is the situation in various internal fixation devices that results into fracture at the junctional level. In the fusion, there is a similar problem. There is stress concentration on the next level, and that produces accelerated degeneration, and that produces pain and paresthesias, and that results into a kind of a new kind of a syndrome. And it has been shown that the fusion accelerates degeneration at the adjacent level compared to the natural history of these patients, and the probability of going into adjacent segment problem is significant at 5-year and at 10-year level. And if you look at it, the surgery or the problem which is related to adjacent segment requires surgery, that is more or less 1% after 10 years or so. There is no significant difference found if you replace the disc, keep the joint or the disc level mobile, and there is minimal chance of adjacent segment disease, and there is no problem of adjacent segment issue subsequently. This whether this patient develop any degeneration or not, it varies from person to person, and you cannot always predict the kind of which patient is going to develop this adjacent segment, which is not. But I think pre-existing MRI degenerative changes will certainly lead to to a sort of state when you like to observe these patients over the period of time, because any degeneration, which may be minor to begin with, may lead to more accelerated degeneration at that level. Moreover, if you have more than one segment which is fused, if you have more than 2-3 segments, similarly the number of fusion segment will increase the risk of adjacent segment disease, which result into junctional failure, both distal and the proximal, depending on how much segment have been fused. Fusion method is also important because if you go posteriorly, the posterior elements, they're all disrupted. Tissues are disrupted, and their innervation is disrupted, and that results into impairment of the tension band principle. And really, the risk of adjacent segment is minimal as compared to the posterior element, because there's not only biomechanical change at adjacent level, but also the whole biomechanics of the posterior element is also disrupted. How do you reduce the risk of adjacent segment? I think you can use dynamic pedicle screws and the rods, which land more softly. You can use sort of other material which are not that rigid, and that lead to sort of a less mismatch between the implant and the host bone, and that result into sort of a lesser risk of degeneration. The other thing is you can use minimal space dissection, because if you dissect it too much, you induce biomechanical or the mechanical change into adjacent disc, and that becomes degenerate. You can preserve the posterior element as far as possible. You should use motion preserving technology. You can diverse and you can disperse these stresses forces at the more than one level, and you can use various hybrid rods or various ligaments or the bands, which you can expect to land softly at the junction level. Before that, I think musculoskeletal health has to be maintained prior to surgery. You should minimize the osteoporosis and sarcopenia, and that can be done with sort of various medical anabolic drugs and means, apart from physical therapy. You should avoid excessive soft tissue dissection and the capsular damage while doing surgery. Minimal invasive technique, they have a very positive role in minimizing the risk of adjacent segment disease, because you're not disrupting any soft tissue element or capsule or the muscle attachment to the posterior elements, and that does not disrupt the posterior tension band principle. I think you should respect the sagittal alignment. When you're considering surgery, you should maintain the sagittal alignment of the fused segment as much as possible, so there's no mismatch between sagittal parameters. You can use various implants and biologicals. Titanium is very good. It is very widely used, and you can use surface engineering methods now which are available. You can have a nano treated implants which are very biologically active and generate new bone and biological activity and promote early fusion. New alloys, molybdenum, rhenium is important. They are very good, biologically very friendly, and they do not create that mismatch between the host bone and the implant. And you can use biologics to increase the bone union. And the transitional mode using various composite rods and also the various bands, they are important and they must be used as much as possible. At the same time, you should respect the sagittal alignment and the deformity which occurs, which has there before surgery, and you should take care of sagittal alignment in these patients. So, in conclusion, I think adjacent segment is a biomechanical sequelae of fusion. The comorbid conditions like osteoporosis, diabetes, metabolic disorders, and neoplastic, they play their own part in expression of adjacent segment disease. They can be minimized by surgical techniques, use of various alloys, and make sure that there is no iatrogenic damage to the muscle and the capsule and other stuff. And keep in mind sarcopenia and the posture, they are important. You should improve the bone health and the muscle health before surgery. And to me, adjacent level disease and the PGK, DGK, they are similar biomechanical phenomena resulting from the fusion in a mobile segment, which may be short or maybe a long one. And it does the same change in biomechanics and results into junctional failure. So I think that can be minimized, as I said earlier, by various medical, surgical, or other techniques. And I think that should be exercised well before surgery. Thank you very much indeed.
Thank you, Dr. Sahil. Our next speaker is Dr. Robert Kuru. He is going to talk to us about anterior lumbar interbody fusion for isthmic spondylolisthesis. Dr. Kuru, please.
All right. Good morning. Good morning, everyone. I'd like to firstly thank the committee and the society for the opportunity to come to Dhaka and join you all in the meeting. I'm very much looking forward to the next couple of days. So I'll be talking to you this morning on anterior lumbar interbody fusion, and I understand that it's not a very popular operation. We've come up not a very popular operation through Southeast Asia, but maybe by discussing its use in context with isthmic spondylolisthesis, we might generate some interest. So here we are. I'm not sure if this is going to work. It is going to work. Maybe here we go. So for those of you wondering why I speak funny, this is where I'm from. We get here via Hong Kong. Newcastle is Australia's 7th biggest city, but it's tiny. It's 500,000 people. So we're quite overwhelmed getting into Dhaka. If anyone wants to come and see some anterior surgery, you're all welcome. Anterior fusion in lumbar degenerative disease has been well established for many years. You know, this is a paper published by the Japanese in 1990 with 30-year follow-up. And one of the things we know about anterior fusion is that it does seem to minimise the rate of adjacent segment degeneration. And I haven't put the paper up here, but Professor Fraser from South Australia has published a very nice study showing no difference in rates of adjacent segment degeneration at 20 years in a matched patient segment having gone a single level lumbar fusion versus those treated non-operatively. The game changed in around 2005 with the development of freestanding implants. So up until this point, usually for stability, we were combining anterior surgery with posterior screws, but cages with integral fixation meant for the first time anterior alone surgery was viable, but the initial recommendation, and the recommendation still today, is that these devices not be used with spondylolisthesis or ischic spondylolisthesis on the basis perhaps of perceived instability. The problem with anterior surgery, or the concern for surgeons, is the incidence of vascular injury, as we've already heard a couple of times this morning. Perhaps the thing to remind you is that you can get vascular injury with posterior surgery. And this is a PLIF of mine, where I've gone through the front of the disc and taken a chunk out of the common iliac vein. And I'll put it to you, when that happens, you're a lot better off being in the front of the spine, seeing the blood vessel, rather than having to get around there from the back. But fortunately, the incidence of it is low. The issue with the standard fusions that we're doing, firstly, is that they also have complications. They may not be vascular, but they're different complications, and they are significant. And the big advantage with anterior surgery is that if you do get a vessel injury, you resuscitate the patient, and that's it. They tend to be short-term complications. They don't have the same longer-term impacts. The other issue with most of the surgery that we're doing at the moment posteriorly is that it does not reproduce lordosis, particularly at L4-5 and L5-S1. And that is where anterior surgery really is the standout. And it's been quite well established, particularly with PLIFs and TLIFs, that in many cases they're kyphogenic rather than restoring lordosis. And at L4-5, L5-S1 is where we need lordosis. What we're going to talk about today is my small experience with freestanding anterior fusion, so no posterior instrumentation. If you go to the literature and have a look, there are numerous papers that have a look comparing PLIF, TLIF and anterior surgery. But you need to have a look at them in detail, because nearly all of them involve putting in some form of supplemental posterior instrumentation. Okay, and that's 360 fusion, that is not ALIF. All right, so this is a 40-year-old patient of mine with an L4-5 isthmic spondy, back and radicular pain. He's had a freestanding anterior fusion, and he's at 5 years now and had a pleasing clinical result. So going back and looking at my own personal series here, so this goes from 2011. I started doing the surgery in 2005, but unfortunately we have upgraded our computer system in the office, so I've lost all of my old records, so we can't go back then. And for 200 anterior cases, 61 of them were for isthmic spondylolisthesis. So these are all my cases. There's no access surgeon involved. I do my own approach. Predictably, most of them are L5-S1. Okay? And L5-S1 is very easy access for surgery. L4-5 obviously is the difficult level, having to mobilise the vessels, and above there also gets a little bit difficult, but the vessels aren't too much of a problem. Slight female predominance, but generally pretty equal split. One of the great things about ALIF is it's fast. So 65 minutes on average. Every now and then you get a case that's a bit more difficult. Take a couple of hours if you have to distract, open up a disc space, do an extensive release, but generally it's a little bit over an hour. And the other thing is the hospital admission is quite quick and return to function is quite quick. Fortunately, in this group, I've not had a vascular injury. I have had a major vessel injury in a multi-level reconstruction in a revision anterior approach, but this is primary operations for isthmic spondylolisthesis. And that is the advantage of the procedure, is all of the complications that we quite typically deal with are low, nearly unheard of, particularly infection, nerve root injury, dural tear. Okay? The risk with the surgery for isthmic spondylolisthesis is the perceived risk of failure of fixation. And unfortunately, I have had 2 cases of failure of fixation in that group. No adjacent segment disease over the course of time of these patients. And I've had 2 patients who've had persistent symptoms where we've gone on and excised the posterior elements. And I've got a 3 there. I've got one fellow who who has that now from an operation 3 months ago. I'm about to go and revise it. This is my failure of fixation case, and I'm not quite sure why I operated on this guy. He did have a spondylolysis. I know that doesn't show up there, but the pathology is not overly impressive. He had a standard anterior fusion. Everything went smoothly, except it was quite notable that the disc space was very distractible, and in hindsight he may have had an instability there that I didn't recognise. It went fantastically well for 6 days, and then rang with recurrent radicular pain. And you can see there that he's fractured through the front of his sacrum and retranslated. So we went back, did a revision anterior approach, took the old device out, put a smaller one in, and then supplemented that with posterior instrumentation. That was in 2013, and I have seen him recently, and he has adjacent segment degeneration with a spondylolisthesis, and he is the same patient as the one who's gone on to adjacent segment degeneration, which is the only one in this series. The other early failure of fixation was this fellow. He's a 46-year-old fellow. He was 2 weeks after his surgery when he decided to take his children on holidays and go to an amusement park, and went on a roller coaster and had a fracture of his end plate. I'm not personally sure that represents failure of stability of the construct rather than the standard of the patient that I operate on. But he's gone on and had some supplemental fixation there and gone on to union. For those who would argue they're unhappy with a freestanding anterior fusion with an isthmic spondylolisthesis, I'll just put this case up to I'm sure, as we all know, bad things can happen however you do things. This is a revision case of a lift that came to me where the cages had subsided. I went and did an anterior-posterior reconstruction, and at 6 days she fractured. And I think one of the risks with the newer implants with indural fixation is if you combine them with posterior instrumentation, the screws come together on a narrow piece of bone. I think that can predispose you to fracture. So we've gone on and done a more significant reconstruction there, which is not what we were after. So there are a number of small series, single surgeon series, again demonstrating that freestanding anterior fusions are stable and they're safe with a low rate of failure. So in conclusion, freestanding anterior lumbar interbody fusion is a viable option in treating isthmic spondylolisthesis. One of its advantages is that it is the most effective technique we have for restoring lordosis at L4-5 and L5-S1, and that may then reduce the rate of adjacent segment degeneration. The incidence of failure of fixation is low, and something I have not discussed, and it's geographically different everywhere, but the cost of an anterior fusion in Australia is about half the cost of a PLIF or TLIF. So there may be an economic argument. Thank you.
Now you are requested, please come over here and take your memento. Rosa Fazlul Haq as well, please come and take your memento. I present you.
Thank you. Oh. I'll take both. Thank you very much.
Now the question and answer session, where we shall get only 10 minutes for this, as we are running short of time. And our overseas presenter also will be connected with us online, and he can make question to him.
Now, you presented degenerative L4-5 canal stenosis with grade 1 listhesis. What treatment option would be better? Any question to him? Maybe Menon, do you want to ask?
So,
Use this one.
not a question really, but it's a comment. The Journal of Neurosurgery Spine has a couple of years back published by Andrea Simmons. There's a paper which says it's a scoring system for degenerative listhesis based on clinical and radiological criteria. So you look at clinical criteria like back pain, you look at radiological criteria like end plate sclerosis on the X-ray, segmental instability on flexion extension films, modic changes on the MRI, the height of the disc space on the X-ray, and the facet joint. If there's a facetal effusion at the same level, that's an additional sign of instability. So looking at all these factors together, you put a score and decide, is there a segmental instability or not? And if there is, obviously fusion is the best choice. And for those who do not have a segmental instability, clinically and radiologically, a non-fusion laminectomy type of procedure should work adequately. So this, to the best of my knowledge, the scoring system, the Simmons scoring system has not been independently validated, but there does exist a scoring system. So this is just for your information. Please do read it.
Thank you. May I request Chinmoy, please come onto the dais and take a seat, please. Yeah. Listen, now it is open to everybody. Anybody can ask any question. But we have very short time for question and answer session. Any question to anybody? Please, go ahead.
Yes, hello. My name is Klaus Schnacke from Germany. Thanks for the great talks. I do have a question to Rob Kuro from Australia. So I perform ALIF roughly 60 per year, so I'm an ALIF believer. I think it's an excellent technique. My question is, however, in my experience, if you do it quite frequently, you can really lower the complication rate. Otherwise, we know that vascular complications occur from time to time, especially in the learning phase. My question now to you is, with regard to the fusion in these isthmic spondylolisthesis, what kind of bone graft do you use? Do you use artificial bone graft? Do you take something, do you use BMP or whatever? Because with BMP, we got 100% fusion rates, but not with bone. With bone graft, it gets a little bit lower. And secondly, do you choose these patients specifically with regard to BMI or something like this? So to avoid the more complicated cases, do you perform angiography CT scan beforehand to avoid the more complicated cases? So do you selective ALIF, or do you do ALIF in all the patients? So selection criteria, as well as how do you achieve fusion?
Thank you. Very good question. So up until 2020, we used BMP. And I guess initially we used allograft bone and swapped the BMP around the time that we started these series. We have a very unusual political system in Australia at the moment where our regulator has taken BFP off the market. Not because of any bad data or because it's unsafe, but there was an issue with Medtronic's original application for BMP, and they're making it resubmit it. So since 2020, we haven't had it. We've gone back using manufactured allograft bone crunch, and one of the things I wanted to do with this series was have a look, compare the BMP and graft groups, and the data wasn't good enough to get any conclusion there, but certainly we are seeing a reduced fusion rate without it. With respect to patient selection, like any operation, as you get more and more experience, you broaden the patient selection, and I certainly do cases now that I would not have done 10, 15 years ago. So BMI is an issue. There's a significant difference. Australia is a fat population. Women, when they lie on the table, tend to have peripheral fat, and it just drops to the side, and you can get in the front quite easily. The men have their fat intra-abdominally, and it can be quite difficult to get access. So we'll do a CT scan and measure, CT scan supine, measure the distance from the skin down to the front of L5, and really what limits your patient selection then is the depth of the retractor blades, and the lever on the retractor blades can become limiting. In some patients, you make a longer incision in the fat, and if the fat is 5 to 10 centimetres thick, you can then put the retractor in the base of that to get better access. Previous hysterectomy is not a problem. Intrapelvic surgery, don't have problems with that. The laparoscopic hernia repairs are a surprise. You're going across, all of a sudden it's all scarred and you have to go above and come around. That's still accessible. Colectomies, if they've had a nice colectomy by a delicate general surgeon, you can get through the scarring. Perhaps if people have had diverticulitis for many years and have had lots of retroperitoneal inflammation, that's maybe something where I would say, no, I won't do it.
So, sir, I have a question to Professor Tariq Sohail, if you permit me. Professor Tariq, my friend. Yes, Professor Islam from Bangladesh. Okay, I have a question to you. You've shown in your slides the adjacent segment degeneration. Suppose if you are fixing the L4 and 5, there is a grade 2 or more listhesis, but there is a degeneration of the disc spaces at the L5 and S1. Do you want to go for the fixation and fusion at the first time along with the L4-5, or it is kept left for waiting for the future adjacent segment degeneration, then you fix it? Which one is better?
Yeah, I think if there is a degeneration in the L5S1, I will include that region. I may not put any spacer out there, but I will certainly stabilize that segment, because I know biomechanically there is much more forces acting on the L4, L5 and S1 level, and that is going to sort of get more degenerated and maybe unstable to begin with passive time. So I think I would certainly consider that to be included in the L4, 5 and include the L5 and S1 as well, extend it there. Because otherwise degeneration will be much more accelerated at that level because of biomechanical angles and the forces which are acting out at that level. Thank you. Yeah.
Yes, one question.
The regime, for example, for low back pain or the specific flexion extension, and you do study is there any prevention measures or not for us to prevent modic changes. Number two, if let's say you inject cortisone or inject steroid, does this will make it worse, or is there any way that we can prevent changes? That's my question.
There are a lot of scope of studies still pending regarding the modic changes. First is there any, is it related with biochemically with any medicines which you have asked? It is not still decided, but I think many researchers think that there is a still scope of study. It's related with the instability. If it is, the spine is very unstable, and it is seen that if you can fuse it successfully, then modic type 1 change, which is inflammatory sort of thing, can be changed either normal or to type 2, which is a more stable thing, in which the red marrow is replaced by yellow fatty marrow and directly go into the type 3, which is sclerosis. So the stability can change the modic sort of thing. So modic changes is definitely related with the stability of the spine. It is debatably related with the non-specific low back pain. Some says that it is related, some says it is not directly related. It may be related with the application of some chemical materials like bone morphogenic proteins, which Dr. Kuru is using in his leaf. So it is definitely related with the it is rate of the modic changes. Type 1 modic changes, non-specific inflammation increases with use of BMP. That was proved in different research by different researchers in there.
Sir, only one question to sir.
Thank you everybody, including Tariq Sohail from Pakistan.
Thank you.
Thank
you. You're welcome. A very interesting
This is the end of our invited talk session. Thank you, sir.
So let us move on to the very interesting session, the debate session.
Thank
It
you,
will be on
speakers.
high grade diseases.
We go on to the next session, which is it's a debate. This is the first speaker is Dr. Sakib. He's going to argue in favor of in situ fixation, that it is sufficient. Dr. Najmus, please.
আচ্ছা থাক অসুবিধা নেই পয়েন্টার কোনটা এইটা কাজ হলো আমনে মাইক
It should be. Yeah, I'm sorry for that. This is the polite thing to do.
শোনা যায় কই হ্যাঁ ওকে আচ্ছা চেঞ্জার কোনটা চেঞ্জার স্লাইড চেঞ্জার Okay, so good morning, respected chairperson and learned audience and participants, senior, junior colleagues. Assalamu alaikum. So welcome to the debate session of today's proceedings, and I will be talking on in situ fusion to be sufficient for high-grade spondyles. So before going to the main discussion, let's discuss the basics of the high-grade spondyles. So basically, the high-grade spondyles are classified according to the Meyerding's classification, type 3, type 4, and type 5. And lumbar 4 sacral 1 junction or the lumbosacral junction is the most affected ones. And this listhesis is considered as a deformity because of its complexity of biomechanical issues and management principles. So the assessment of these cases are very crucial, and it depends on specific X-rays like the dynamic ones and also the spondylograms for the balance of the spine and as well as the pelvis. So, and we have to assess with the MRI and the CT for the neurological components and the compression of the severity of the compression of the high-grade spondyles. So there had been a long-standing debate for the management of these type of cases, whether to go for a conservative or to surgery or in situ fusion or reduction, or a debate according to the approach, whether it's posterior or anterior and so on. So basically the management depends on understanding the individual patient-specific types of the listhesis, disability, symptoms of the patient, presence or absence of instability, and the biomechanical issues. Last 2 decades had been a game changer regarding the biomechanics by coining the term pelvic balance by Resco at 2007, which has led to the classification system of the spinal deformities study group, which has been validated and had been tested for its reliability both intra-observer and inter-observer. So this is the classification of the SDSG group. You can see the basic parameter, the pelvic parameter on which the classification has been made is the pelvic incidence. So this is the diagrammatic presentation of the pelvic incidence, and this is important to classify and differentiate between the low grade and high grades. So the High-grade listhesis is further classified according to the pelvic tilt, whether the pelvis is tilted, anteverted, or retroverted. And another important thing is the spinal balance, which can be understood by the C7 plumb line. And these are other parameters which are associated with it. So spinal balance, spinopelvic balance has some parameters which are very important to understand and assess for high-grade spondyes and assess and decide regarding the surgical management of high-grade spondyes. Another two important angles which is required to understand is the lumbosacral kyphotic angle and the slip angle. So the management algorithm starts from assessing clinically as well as the instability, disability, and then assessing the spinal balance, and then deciding on the pelvic parameters. So depending on these three steps, we can end up in basically two types, depending on the balance of the spine, whether it is balanced or unbalanced. So if the spine is balanced, it doesn't matter in most of the cases whether the pelvis is balanced or not, or the pelvis is anteverted or retroverted. In special cases of retroverted pelvis, other than that, in all cases, in situ fusion can be done very successfully, and that has been supported by the literatures as because the listhesis of L5-S1 level, which is very much depends on patient-specific factors and the compensatory mechanisms, and they have also provided that other than in situ fusion, instrumentation or reduction should be done only for the SDSG 6 group or the last group of the patient where the spine is unbalanced as well as the pelvis is unbalanced. So this is a short-term recent studies, a list of studies where they have studied for less than 5 years and have seen the ODI, SRS scores and SF36 scores. All of them were very much comparable with the normal studies. So these are the long-term studies which has been published recently by in Indian Journal of Orthopedics by Dr. Kailash. So he has presented long-term results of two different authors for 14 years and 17 years in mean, and they have found that the overall outcome of the patients going with in situ fusion is very much satisfactory for the long period of time, considering the ODI scores and the fusion status. There is another study which has been published in Eurospine Journal in 2018 where they have shown there had been no difference with the normal population regarding the pain status, functional status, and mental health status. The same also, there had been another study in Sweden where they have included a large group of population of almost 9,000 comparing with the normal group, and they have found no significant difference between the mental health and the social function and other functions as well. So this is the most recent study that has been published in the JBJS regarding the balance. The maintenance of spinal balance has been present and continued for almost 3 decades. So considering all these facts, we can summarize as follows as that most of the high-grade cases, high-grade spondyes can be done in situ fusion based on assessing the spinal balance. It requires lesser operative time, lesser bleeding, and lesser complication rates. And studies which are available here in different parts of the world, from different parts of the world, shows that the short-term and long-term results can comply with the optimum clinical and radiological outcome. So thank you for your patience hearing. Thank you.
Yes, he will virtually present. He will virtually join the debate. He is Dr. Jawad Salim from Pakistan. Online.
Assistant Professor, Spine Surgery at Doctors Hospital and Medical Center. Assalamu alaikum everyone, good morning. My name is Dr. Muhammad Jawad Salim. I'm working as an Assistant Professor, Spine Surgery at Doctors Hospital and Medical Center, Lahore. My today's talk with you is regarding the great debate with spine surgeons in the cases of the high-grade spondylolisthesis, whether you should reduce it or you should fix it in situ. That's our today's debate, and I would like to talk about the reduction which provides the optimal outcome. And that's the debate. When a patient comes to you with the high-grade spondylolisthesis and you want to know where to go, right or left, and which one is the right, that's the time to decide. I will not go detail in the anatomy and everything. I will go for the clinical evaluation. Really, the patient present to us with lower back pain, with occasionally radicular symptoms and compensatory lumbar lordosis, pelvic retroversion, and the thoracic kyphosis is the postural abnormalities the patient usually presents with you. And when you examine the patient, and you can feel a visible and palpable step off at the spondylolisthesis site, and the tenderness in the lumbosacral dorsal fascia, paraspinal muscles, and the SI joints. And the lumbar flexion and the extension is significantly limited. And to the gait assessment, and most of the patients, due to the pelvic abnormalities, they walk with the crouch gait. And briefly, there are a few terms which you need to know if you are dealing with the high-grade spondylolisthesis. The first one is the lumbar lordosis, and the lumbar lordosis is the angle between the superior end plate of the L1 and the superior end plate of the S1, and which means is usually 46.5 degree. And the other thing is the sacral slope. Sacral slope is the angle between the superior end plate of the S1 and the horizontal line. That's sacral slope with the mean angle of the 39.4 degree. The next term is the pelvic tilt, PT. It's the angle between the superior end plate, the center of the superior end plate, a line is drawn to the center of the head of the femur, and a vertical line. That's the pelvic tilt, and the average angle is the 12.3. And this is the pelvic incidence. That's again the line drawn from the center of the S1 and the head of the femur, and the other line is perpendicular to the S1 superior end plate. This is your pelvic incidence, and the mean value is 51.7 degree. So high-grade spondylolisthesis is associated with the abnormal high pelvic incidence angle, which is shown over here. Another term which you need to know is the slip angle. Slip angle is the most sensitive indicator of the potential instability and is used effectively for the prognostication. And if the slip angle is more than 40 to 50 degree, and there is increased risk of the high-grade spondylolisthesis, here you can see it's the angle between the inferior end plate of the L5 and the superior end plate of the S1. High-grade spondylolisthesis. This is again the terms you need to know is whether it's a balanced pelvis or the unbalanced pelvis. Balanced pelvis means there will be a high slip angle, which one shows in the red, and the low pelvic tilt. This is the balanced pelvis, and the other is a unbalanced pelvis or the retroverted pelvis. It means the low, this sacral slope is low and the pelvic tilt is high. It's the retroverted pelvis. There is a spinal deformity study group. This is a study group of the 43 qualified spine surgeons, and they divided it on the radiographic measurement of the slip grade and spinopelvic alignment. In the low grade and high grade, low grade is less than 50% and the high grade is more than 50%. And here in three types, in the type 1, depending on the pelvic incidence, in the type 1 pelvic incidence is less than 45 degree, type 2 is between the 45 and the 60 degree, and the type 3 is pelvic incidence is more than 60 degree. And with high grade was more than 50% degree, this is again the type 4, which is with the balanced pelvis. Balanced pelvis means high sacral slope and the low pelvic tilt. Type 5 is retroverted pelvis. Retroverted, low sacral slope and the high pelvic tilt. And then the type 6. Type 5 is with the balanced column, and the type 6 is retroverted pelvis with the unbalanced column. This is again showing the L5S1 spondylosis is low grade and the high grade with the type 1, 2, 3, 4, 5, and it's again the same thing. So the decision is here regarding the management in the patients with the unbalanced high-grade spondylosis. It has been suggested that the reduction strategy should be considered by repositioning the L5 spinal segment over the S1 in unbalanced high-grade spondylosis. Both the pelvic retroversion and the abnormal lumbar lordosis can be decreased, leading to improved pelvic balance. So the indications are with the patients presented with the persistent symptoms, failure of the conservative management, and the radiographic parameters suggestive of imminent sleep progression and significantly biomechanical stress and the global sagittal balance. The surgical technique options: in situ fusion techniques using the posterolateral anterior circumferential approaches. The other option is fusion and the reduction combination techniques. And the third is vertebrectomy. Problems with the in situ fusions, which my other colleague discussed, is the pseudoarthrosis, when the 70 to 80% of the fusion is radius, and the loss of the motion segments, and progression of the sleep despite the solid fusion, and neurological deficit. Fusion with the reduction. Individuals with the evidence of the abnormal posture, they are the candidates for the fusion with the reduction, because it restores the global spinopelvic balance and improve the biomechanical environment for the fusion. And what are the indications for instrumental reduction and the fusion techniques? The candidates with the high sleep angle with the more than 45 degree or the severe sagittal imbalance. And the patients who are increased risk of the pseudoarthrosis with in situ fusions, they are the candidate for the reduction. And these are the preoperative L5 radiculopathy, which needs to be decompressed, high-grade dysplastic spondylosis, hypermobility of the L5S1 segment, with a small transverse process where you think in situ fusion will not work, and the sacral dysplasia with a trapezoidal L5 vertebral body and the rounding of the sacrum. What are the current methods of the reduction? Children with the flexible deformity can go for posterior leads followed with extension costing. Patients in home reduction and the fixation is indicated. Posterior reduction and fixation with segmental instrumentation. And the other adults with the fixed deformity, you can go for the vertebrectomy and the reduction, or you can go for the stage reduction and the segmental instrumentation. Here's one of the technique: posterior reduction and the fixation instrumental reduction. It shows first the gradual application of the distraction and then the posterior translation. This is the distraction, then the posterior translation, and then the sacral flexion. Now with the collagen stress relaxation, it leads to reduction of the without the anterior release. Do it posteriorly. Here is the trial, and you put it in the between the disc space and then distract it, and then with the instrumentation you pull it back. The other option could be the stage posterior reduction for spondylolisthesis, because the nerve root doesn't take the stretch of more than 2 to 5 centimeter. Then sometimes you need to go for the stage reduction with the sacral domostomy. And the other option could be the vertebrectomy. And with the patients with adults over 30 years with long-standing deformity and the inflexibility, because if you directly reduce, can lead to the foot drop and other issues. And this is one of the patient presented with the high grade. I think this is not very much clear, but you can see the lumbar lordosis increase. And here you can see the high grade spondylolisthesis. Here is L5 and this is S1. And on the flexion, the deformity is increased. And this is MRI. You can see here that the slip of the L5 over the S1. And here, this is the power picture of the reduction. And this is after the reduction. And this is the post-operative radiograph. This patient. This is few intraoperative pictures is showing the dural thecal sac and the S1 root and the L5 root. This is the key. These all roots should be decompressed. Here you can see that's all L5 nerve root is all cleared. So it doesn't take them much stretch while the reduction, and that's what the key. And again, intraoperative pictures, the cross link is applied, and yeah, you go. This is the pre-op follow-up with the decrease in the lumbar lordosis, and this is the pre-operative picture and the post-operative. These are the few studies, and with the high-grade spondylolisthesis in the adults, current concept and evaluation and review article which is published 2020 in International Journal of Spine Surgery. They concluded fusion in situ techniques are often technically easier to perform and provide low risk of the neurological complication, whereas reduction and the fusion techniques offer a greater restoration of the global spinopelvic balance. Another article published in the Spine Journal, Spinopelvic Alignment After Surgical Correction for the Developmental Spondylolisthesis. This is the retrospective study of multi-center with 73 patients and follow-up of the 1.9 years after the reduction and the posterior fusion with spinal instrumentation. And they concluded proper repositioning of the L5 over the S1 significantly improves the pelvic balance in the lumbar shape by decreasing the abnormally high lumbar lordosis and abnormal retroversion. Another article, evidence-based review. This is again the review article with evidence-based surgical management of spondylosis reduction in arthrodesis by Longo. And there they included the 8 studies, 165 procedures, with the reduction and the arthrodesis and the 1-1 procedures involving the arthrodesis in situ, and they concluded the reduction of the high-grade spondylolisthesis potentially improves overall spine biomechanics by correcting the local kyphotic deformity and reducing the vertebral slippage.
He's a better speaker, so I'll choose his method. So please don't go away with that impression. That's not the idea. Okay? Thank you.
Now take your memento, please.
Sir,
Dr. Joath, you will send your memento to you.
Sir, can we participate within this debate or not? No, not participate at all.
Thank you. And now,
yeah. So we now move on to the case-based discussion, and Dr. Faisal, who's going to do this? Yeah. Dr. Faisal Hassan will talk about foraminal stenosis.
Sir, after the talk of Dr. Faisal Hassan, we have a tea break, and it is only for 15 minutes. Please, dear audience, we have a tea break after the talk of the Dr. Faisal. So, After finishing his talk, everyone we go to the lobby and take our breakfast.
Good morning, everyone. Greetings from UK. I'm Mr. Hassan, working in the Royal Orthopedic Hospital in Birmingham. It's the largest spine center in UK. Today, my talk is regarding lumbar foraminal narrowing. How do you manage this? So, foraminal narrowing is a slightly difficult situation for any spine surgeon. And most of the time, when you plan to decompress the lumbar foraminal narrowing, the patient will require instrumented fusion at the same time. And the problem is often there are inadequate decompression on the lumbar foramina. So there are various classifications of foraminal narrowing, but I don't think any of them has got any clinical validation or significance. The patient symptoms is the main indication for any sort of intervention. There is a classification based on the MRI scan, 1, 2, 3. And there's also an Halim Bochu CT classification, who is one of our colleagues. Again, the clinical signification, I'm not sure, and not fully validated. Let's discuss some cases. We've got a 68-year-old man, diet-controlled diabetic, smoker. His symptoms is only right-sided radicular and stenotic leg pain. He tried all sorts of conservative management and also had nerve root injection with transient benefit. And this is his X-rays and MRI scan. Sagittally, he is slightly balanced, but if you see, he got a huge region of scoliosis. And you can clearly see at the L3 and L4 level, there are quite significant foraminal narrowing. It's only on the right-sided foraminal narrowing. The left-sided, there's no foraminal narrowing. And here is the CT scan of this patient, and you can clearly see there's a big osteophytes, and there's a foraminal narrowing, and there's no central canal narrowing. And a lot of the patient or the spine surgeon, the main goal of the surgical intervention is to symptom relief, to decompress the foramina. He is not symptomatic from his deformity, either sagittally or the degen scoli. So if you think about normally what we should do, if you want to do a posterior decompression and a 2-level facetectomy, T-leaf, because of his degen scoli, he will require a long segment fixation, possibly from lower thoracic to pelvis. So it is quite a big deal for only a radicular leg pain. So what we did a standalone 2-level X-leaf procedure, one with an in situ fixation, one is a standalone, and definitely it has increased his foraminal height, and the patient is quite a bit of symptom free, and it has also not significantly deteriorated his degen scoliosis following the surgery, and the patient is quite satisfied with the outcome of the surgery. Now, another case, a 65-year-old male had an L5S1 decompression, had an L45 decompression, 2019 had a revision decompression on both the level, and 2020 had an L4 to S1 fusion, redo decompression, and a T-leaf procedure. After all of them, he presented with right-sided leg pain only, and a very typical of L3 distribution, had a significant improvement following a CT-guided injection at the right L3 nerve. You can see his problem is here in the L3 nerve, in the nerve root, both in the CT and MRI scan. Again, to decompress that level and extend the fusion is a big undertaking. That will be his 6th lumbar spine surgery, though it's not in the L3 level. So what we did, we extend the fusion with an X-leaf procedure with an in situ fixation to increase the height of the foramina, and the patient was quite satisfied with the outcome of the surgery. Sorry. Another patient, a 59-year-old lady with ongoing back pain and parastatic pain in the legs. She had an L4 to S1 fusion in 2005 and presented with left S1 radicular pain, injected, which improved, In the meantime, she had a breast cancer and went through all sorts of oncological management. So this is her X-rays. You can see she is slightly, but there is a huge degree of mismatch between PI and lumbar lordosis. So again, if you extend the fusion, she will require the maintenance or to redo some increase of lumbar lordosis to make her straight. So what we did a two-level X-slip procedure and we extend the fusion, which has increased his lumbar lordosis and overall sagittal balance. So if you see over the course of time from 2012, she has progressively mismatched, but doing extend the fusion and increasing some lordosis at those two levels, she has more balance. It's not perfect, but she is significantly more balanced than she was before. So it is the X-slip procedure, and there's a short video of X-slip procedure, and it is from a company from Nivesiv. I don't have any financial correlation because this is the implant we use in our hospital. No voice in the video. Okay, sorry, the sound system is not working, so we are. I don't know whether we X-slip procedure done in
a small incision on the side of your body. Dilators will be used to direct the path to the affected disc space, while advanced monitoring will help the surgeon avoid local nerves. Once the safest path has been determined, a retractor will be utilized to hold the skin incision open, providing access and visibility to the affected area. The diseased or damaged disc is removed to reduce pressure from the symptomatic cord or nerve root. An appropriate implant chosen by your surgeon will be placed into the disc space to restore the proper disc height and provide mechanical support while bone grows between the vertebral bodies during the fusion or bone healing process. That segment of your spine will eventually stabilize once fusion occurs. Generally, some method of internal fixation will be used to act as a stabilization device or internal brace to help hold everything in place while fusion occurs. This could be a combination of screws and plates that are affixed to the adjacent vertebrae. Your surgeon will determine what, if any, kind of fixation is necessary during the procedure.
So X-slip procedure, in fact, is quite a nice way to address the foraminal narrowing, though it has limited indication and has some potential complication, especially about the position of the lumbar plexus, and it's very difficult to do it in the L5S1 level, where definitely the ALIF is the lateral ALIF is the desired procedure. So it is a surgeon's preference which technique do you want to use for treatment of lumbar foraminal narrowing. Thank you.
Thank you, Dr. Faisal Hassan. There are no questions in this particular presentation. So we conclude the session. I thank my co-chairman and moderator. We now break for tea. Is that right?
So
Ladies and gentlemen, tea break.
We have only 15 minutes, sir. Thank you very much for patience hearing. And Dr. Faizul Hassan, please come over there to take the memento, please.
Your audience, please. Everyone are invited to the lobby for taking your tea break. Okay, tea is available. Please.
এই ল্যাপটপেই তো হবে এই ল্যাপটপেই চেঞ্জ করা যাবে না এই ল্যাপটপেই চেঞ্জ করা যাবে না আচ্ছা ঠিক আছে আবার এটা দিয়েও চেঞ্জ করা যাবে না
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe.